Welcome to The Explainer. One of the most common reasons a person will ever see a doctor is also one of the trickiest diagnostic puzzles you're going to face. So today, we're tackling the headache. We're going to build a practical, rock-solid framework so you can approach this super common complaint with real confidence and precision.
This right here is the fundamental question that has to be running through your head every single time a patient comes in with a headache. Is this benign, or is this a sign of something that could threaten their life or their brain? This entire guide is designed to give you the tools to answer that critical question every single time.
Okay, first things first, a really crucial piece of anatomy. The brain itself can't actually feel pain. Nope, the pain that we call a headache comes from the activation of these pain-sensitive structures that are surrounding the brain. We're talking about the dura, the major blood vessels, and the cranial nerves. Understanding that is key to seeing why things like inflammation or vascular problems can cause such intense, debilitating head pain.
All right, so here's our game plan. We're going to start with the scope of the problem. Then we'll dive into the single most important classification you need to make. After that, we'll profile the usual suspects, learn how to spot the really dangerous exceptions, and finally, we'll put together your complete diagnostic toolkit.
So let's start by just framing the problem. Headaches are incredibly common, but you know what? That familiarity can be a real trap. Your most important job is to stay vigilant, to keep a high index of suspicion, and be able to spot that one rare, dangerous cause among the many, many benign ones.
And this chart really puts that challenge into perspective, doesn't it? In a typical primary care setting, you are going to see a sea of tension headaches, sinus pain, and migraines. But you just can't afford to get complacent, because hidden somewhere in that sea could be a subarachnoid hemorrhage or a brain tumor. And the stakes for missing those are obviously incredibly high.
All right, now for what I think is the most crucial concept in your entire evaluation. This is the central pillar of headache diagnosis. Your first and most important job is to separate all headaches into two fundamental categories. Everything else you do is going to flow from this one decision.
And this slide really simplifies your entire goal. A primary headache is the disease, like a migraine. A secondary headache, on the other hand, is just a symptom of something else going wrong. So your job, first and foremost, is to be a detective, to meticulously hunt for clues and confidently rule out a dangerous secondary cause.
So what's the crucial point here? It's that before you even think about ordering a CT scan, you have to use your most powerful diagnostic tools, your ears, your brain, and your hands. A really meticulous history and a focused neurologic exam are going to give you almost all the information you need to make that primary versus secondary distinction.
Okay, so let's say you've confidently ruled out a dangerous secondary cause. Now it's time to identify the culprit. So let's build a really clear profile for the three most important primary headache syndromes you will absolutely see in practice.
First up, the tension-type headache. This is the most common kind, right? It's that classic, bilateral, band-like pressure around the head. The pain is usually mild to moderate, and critically, it doesn't stop the patient from going about their day. It's annoying, but not disabling.
Next, the migraine. And listen, this is not just a bad headache, it's a full-blown neurological event. The pain is often this unilateral, throbbing beast, but the real key is the company it keeps: nausea and extreme sensitivity to light and sound. A true migraine is often disabling. It's the kind of thing that sends a patient to a dark, quiet room just to get some relief. And finally, the cluster headache. This is one of the most painful conditions known to medicine, period. The pain is always one-sided, just boring into the area around one eye. And it comes with what we call autonomic features on that same side. Think of the autonomic nervous system just going haywire, causing a tearing eye, a runny nose, maybe even a droopy eyelid. The attacks are pretty short, but they come in these vicious, rapid-fire clusters.
This table just lays it all out so clearly. You can see the distinct profiles of these three syndromes: the location, the quality, the severity, the presence of those autonomic signs. These are your diagnostic fingerprints. Seriously, commit these key differences to memory. Pause here if you need to, and you'll be well on your way to a rapid and accurate diagnosis.
Okay, so we've met the usual suspects, but now it's time to build our safety net. Let's focus on how to catch those dangerous secondary causes by learning to recognize the red flags. To make them easier to remember, let's group them into three categories of alarms: alarms in the headache story, alarms from the patient's general health, and alarms on your neurologic exam.
First up is the story alarm, and this is the most urgent one of all.
If a patient describes the worst headache of my life that exploded to maximum intensity in an instant, a true thunderclap, you must immediately consider a subarachnoid hemorrhage. This is a true neurological emergency.
Next are these systemic alarms. When the headache doesn't come alone, you have to pay close attention. A fever and a stiff neck should make you think meningitis. A suspicious rash could point to meningococcemia. Unexplained weight loss, that could suggest malignancy. These signs tell you the headache is just one piece of a much larger systemic puzzle.
And finally, we have the exam alarms. See, during a primary headache, the brain itself should be working normally other than the pain. So if you find any focal neurologic signs, like weakness on one side, or any change in mental status, from subtle confusion to a full-blown seizure, you have to suspect a structural problem in the brain.
So here it is, your complete can't-miss checklist, which brings all those alarm categories together. Think of this as your cognitive safety net. A brand new headache after age 55, a headache that's progressively getting worse, one that's triggered by coughing or exertion. These are the symptoms that demand you stop, think, and investigate further.
Okay, so a patient comes in and they have one of those red flags. What do you actually do? How do you proceed? Let's outline your diagnostic toolkit and the logical workflow you should follow to get to the right answer. Your approach should always follow this logical sequence. You start with your clinical skills, a great history and exam. If and only if you find red flags, that's your trigger to escalate to neuroimaging. And if your suspicion for something like meningitis or a bleed is still super high, despite a normal CT scan, that's when you consider a lumbar puncture.
And this is why imaging, when you use it correctly, is so incredibly powerful. A patient might tell you about a headache that only happens when they stand up. An MRI like this can cut right through the mystery, revealing the cause, diffuse meningeal enhancement, the classic sign of a cerebral spinal fluid leak. Now, quick note on which scan to order. A non-contrast head CT is your go-to for emergencies. It's fast and excellent for spotting acute blood. An MRI gives you way more detail of the brain tissue itself, making it better for suspected tumors, infections, or more subtle things like this CSF leak.
So let's just hammer this home one more time. Remember these key indications for imaging: the thunderclap headache, any headache with an abnormal neuroexam, a new headache in an older patient. Think of these as your non-negotiable triggers for ordering that CT or MRI. And that's really the bottom line. With this systematic approach, thinking primary versus secondary, profiling the usual suspects, and always screening for those red flags, you can transform the headache from just a simple complaint into a diagnostic puzzle that you are fully equipped to solve. You have the tools now. Go solve it.